Hi, this is Nursinga. Today you're watching Sensory and Neurological Conditions for Pediatrics. The ears contain receptors of the 8th cranial nerve, the acoustic nerve. The ears serve two main functions, hearing and balance, and they're divided into three sections, the external, the middle, and the internal structures. In the newborn, the tympanic membrane is almost horizontal. It's more vascular, and it has inconsistent light reflexes. The eustachian tube, which provides ventilation, protection, and drainage, is shorter and straighter than in adults, increasing their risk for ear infections. Hearing impairment can pose a significant challenge to the growing child. It can affect speech, language, social and emotional development, as well as behavioral and academic achievements. We can have hearing impairment from both congenital deafness or acquired deficiencies. Acquired hearing impairment includes problems from colds, medications, exposure to loud noise levels, infectious diseases, and blockage of the ear canal from things like earwax, which is cerumen, or from foreign bodies like peas, toys, stones, things like that. Congenital hearing loss can result from defects in the transmission of sound to the middle ear, damage to the auditory nerve or ear structures, or a mixed loss that involves both a defect in the nerve pathways and interference with sound transmission. Behavior problems may arise because these children do not understand verbal directions. Routine newborn screenings are performed before discharge. During the hearing screening, a lack of response by the infant to sounds or music, or the lack of a startle reflex in infants under 4 months of age, is the first sign that a hearing impairment may exist. There is medical or surgical treatment, such as hearing aids, cochlear implants, and communicating with the child using aids such as lip reading, sign language, writing, visual aids, the iPads with the pictures on the screen, and keep in mind that body language also can help a lot with communication. This is a cochlear implant, and just a good nursing tip. When addressing a hearing impaired child, do the following. Be at eye level, be face to face, establish eye contact, speak in short sentences, and avoid using exaggerated face or lip movements. They often say that people who can hear are the best lip readers because you can associate sound with the movements. So people who have hearing impairment who are trying to lip read need you to be as normal as possible to associate the movements that they're seeing with the sounds that they're expecting. This is a normal eardrum. Notice that you can see a cone of light and you can see the underlying structures, the malleus, the stapes, and the incus. The normal eardrum or tympanic membrane is kind of a pearly gray in color. So let's talk about some infections of the ear, starting with otitis externa, or an inflammation and infection of the external ear structures and canal. In otitis externa, the meatus is acutely inflamed, tender, and weeping freely. It is extremely painful to handle, and nothing can be seen of the interior of the canal without causing the patient acute pain. Otitis externa is an acute infection of the external canal, as I said, often referred to as swimmer's ear. The patient reports pain and tenderness on manipulating the pinna or the tragus. The tympanic membrane is usually normal, and you want to rule out the presence of a foreign body, cellulitis. Diabetes mellitus can cause a yeast infection within the ear, or herpes zoster can actually present within the ear as well. Treatment depends on whether it is a bacterial or viral or yeast infection, so irrigation and topical antibiotics or antivirals, and then a cotton wick to the outer third of the canal is often used to help drain, and that will also kind of open up the canal and help drain things out as well. Acute otitis media then is inflammation of the middle ear and the structures lined by the mucous membranes. And this can include the mastoid sinuses, the middle ear, the eustachian tube, which protects the middle ear and provides drainage and equalizes air pressure, and infection of the throat can easily spread to the middle ear and the mastoid because of the connection with the eustachian tube. It occurs most often after upper respiratory tract infection and is caused by various microorganisms such as Streptococcus pneumoniae and Haemophilus influenza. Infants are more prone because of ear anatomy, like those short, straight eustachian tubes, and their humoral defense mechanisms are immature, so they don't have a lot of antibodies floating around in their bloodstream. The infants going to bed with a bottle of milk or juice also are an increased risk because the eustachian tube can easily leak the fluid that they're drinking up into the ear if their head is flat while feeding. So again, on the left, we have a normal eardrum. You can see that nice light reflex. The tympanic membrane is kind of a pearly gray, and you can see the underlying bony structures. On the right here, you see acute otitis media, where we lose that nice pearly gray color. Underneath, you can see purulent fluid. The light reflex is gone, and the structures really are no longer visible. And you can also see it's very reddened or injected. The vessels themselves are very full of blood and irritated. So again, just a quick nursing tip. Signs and symptoms of ear infection can include rubbing or pulling at the ear, rolling the head from side to side, hearing loss, loud speech, inattentive behavior, articulation problems, and speech development problems. Especially in younger children, they can't always understand what it is that is hurting them or bothering them, so we need to be alert to these signs and symptoms and recognize that they need to be evaluated. Chronic otitis media is when the tympanic membrane and the underlying structures become chronically inflamed or infected when there's either back-to-back or persistent effusions or infections for more than 3 months. And the eardrum can rupture if an abscess forms, but it also can spread to mastoiditis, so this is a fairly concerning issue. The treatment is broad-spectrum antibiotics, and remember, in children under 3, you want to pull the pinna down and back, and for over 3, pull the pinna up and back. Surgical interventions, such as placing ear tubes, are used when conventional methods are not successful or when children can't seem to clear the infection despite antibiotic use. So children with chronic otitis or recurrent otitis media may require what's called a myringotomy, and this is an incision in the tympanic membrane, and then usually suctioning out the pus or the purulent fluid behind the tympanic membrane to relieve the pressure with the installation of a tube, which, an ear tube, we often call them, that looks just like a bobbin. So it's a small tube that has a flange on each side that's inserted in so that there's a flange on the inside of the membrane and on the outside of the membrane. It helps hold it in place, but it allows for any fluid that enters from the eustachian tube to drain out, and then the installation of ear drops into the ear canal that then also cross over into the inner ear and the eustachian tube. Instruct caregivers that the child's condition may improve dramatically after antibiotics are taken for a few days. To prevent recurrence of the infection, they must continue to administer the medication as prescribed until the course is fully completed. And it's important, for you to watch them deliver the drops appropriately. So you always want to do that teach back. The doctors will give instructions on whether or not they want any cotton balls or anything like that in the ear. or whether or not there'll be any restrictions on swimming. But the little tube that they put in there does look like a little bobbin. Oftentimes they're white, they may be blue or yellow, and they may fall out. So as the child grows, they may actually just fall out. So sometimes, parents will call and they'll say, I found this little, bobbin looking thing on my child's pillow last night. And oftentimes there's a little bit of, crust or blood or a little bit of pus or something on it, and they get very worried. Just, reassure them that that's normal and have them make an appointment to follow up either with their pediatrician or with ENT. Barotrauma to the tympanic membrane happens when there is a drastic change in pressure. And this happens with things like flying in an airplane and ears that can't be equalized, or with dive trauma, so children who are scuba diving, and obviously these would be older children. Things that can help equalize the pressure between the eustachian tubes, like the tympanic membrane, kind of the inner and outer pressures, would be yawning, chewing gum, sucking on a bottle. Decongestants can also be taken, but must be taken at a time to ensure they're at their peak effect when needed for descent. And then for scuba diving, descent or ascent should be slow enough to allow for equalization of pressure. And we recognize barotrauma when there's like sensory hearing loss and vertigo, nausea, or vomiting. Those are early signs of what we call decompression sickness when it occurs after the ascent phase of diving, and the diver should be referred for medical care. It's really important that kids with like recurrent otitis media or significant sinusitis, an active cold, don't dive because of the risk of barotrauma. So that was ears. Now let's talk about eyes. So the eyes begin to develop at 4 weeks of gestation, and the retinal vessels are not fully developed until the 40 weeks. So preterm babies have very limited eyesight. And for that reason, preemies often have lifelong vision problems. Newborn sight is not mature, and the shape of the eye is less spherical in the newborn. Tears themselves are not present until 1 to 3 months of age, and depth perception does not begin to develop until about 9 months of age. So at birth, they can recognize kind of light and dark, and they can start to see kind of outlines of shapes, but they don't really start to have clearer vision until much later. When you're doing your assessment of a newborn or a younger infant, again, your assessment wants to start while they're in that very quiet alert phase before you have upset them. So you want to count your respirations while they're resting, and then you want to look at their overall kind of appearance. And at birth, the quiet alert infant will respond to visual stimuli by cessation of movement. So it kind of catches their attention and they stop doing that constant kind of like little arm and leg movement and just like freeze and focus on whatever it is that caught their attention. And so that's very normal to have these like little moments where they just kind of freeze and they stare. Visual responsiveness to the mother during feeding is noted, so they appear to be making like eye contact or studying their mother's face, or if they're being bottle fed, whoever's feeding them. And the ability to focus and follow objects in the first few months of life should be documented because that's a normal growth and development milestone that we track. Coordination of eye movements should be achieved by about 3 to 6 months of age, and that's where they can really track objects. And that both eyes are moving, and you'll notice as they get older, they also start like following things, like they get excited about things, and they'll start to reach for things. So we start to see some eye-hand coordinating as well as they get older. As far as visual acuity, you can't really put up a Snellen eye chart for a young child that doesn't know their numbers or their letters. So we've looked at all sorts of different eye charts for kids. And there's different ones that have like pictures that they might recognize, like a tree and a boat and a house. But this one is actually well vetted, and it's just a hand. They hold their hand up and they turn their hand in the direction that the hand signal is going. As the evaluator, you can imagine that you're trying to put together what they're doing with their hand versus what's on the picture. So you might get a little turned backwards, but do the best you can. So visual acuity is the ability of the infant to fixate and focus on an object, usually demonstrated by 6 weeks of age, but testing doesn't begin until about 2 to 3 years of age. Make sure that if you are assessing the infant's ability to track an object, that it does not emit a sound. So if you're using your badge or keys or whatever, it shouldn't like tinkle or chime, and it shouldn't be a toy that squeaks or buzzes or rings. Dyslexia usually is not evident until children start to read, but it is probably the most common reading disability that we see, and it involves a defect in the cortex of the brain that processes graphic symbols. So basically it changes the kind of shape and direction that the letters occur in, and it makes it just more challenging for the child to read and to write and put letters in the correct order. Children with dyslexia tend to be incredibly bright and then just have a hard time with sequencing. So remedial instruction oftentimes can be very effective, but another reason why screening is so important, so that we can support them how they need to be supported so they can be successful. Amblyopia is the loss of vision or reduction of vision in one eye, and this occurs when the eyes, oftentimes referred to as lazy eye, but one eye does not track as well as the other. And so children give preferential vision to the stronger eye and stop receiving input from the lazy or weaker eye. It is correctable with things like glasses, an opaque contact lens, or patching of the good eye to force the weaker eye to receive input and stimulus. And in severe cases, sometimes surgery. This also can be seen with strabismus or cross-eye, and when that occurs, the outcome sometimes is poorer. So let's talk about strabismus then, and that's cross-eye. So these terms that you see here, esotropia, exotropia, hypotropia, and hypertropia, are terms that are used in relation to strabismus, which is also known as cross-eye. In this condition, the child's not able to direct both eyes in the same direction, so the lack of coordination between the eye muscles or that direct the movement of the eyes is due to kind of a weakness on one side. And when that coordination does not occur, the brain disables one eye essentially to provide a clear image. So the disabled eye then can develop permanent visual impairment because of sensory deprivation. There is both a non-paralytic and a paralytic type. And so again, we want to patch the unaffected eye to force the affected eye or the weaker eye to become stronger, or they'll put glasses on the child and essentially white out or black out the good eye to force the weaker eye to work. Surgery is an alternative if that does not work. So with esotropia, there's marked inward turning of the eyes, and with exotropia, there's an abnormal outward turning of one or both eyes. With hypotropia, one eye turns down, and with hypertropia, one eye or both turn up. So when we're looking at or screening kids for things like strabismus, think about, does this child appear to be squinting a lot in order to focus when they're looking at the board, or are they frowning a lot? Do they lack eye-hand coordination? So when they reach for an object, are they missing it? Do you notice them covering one eye or tilting the head in order to focus on an object? Or do they complain frequently of dizziness or headache? And if you're working in the pediatric world, especially if you're working in like a school in early childhood education or in an elementary school, these are things that, the teachers have been taught to recognize as well, but definitely would cue you that the child needs referral and screening. Eye strain is inflammation, aching, burning of the eyes, squinting, short attention span, frequent headaches, difficulty with schoolwork, inability to see the board at the front of the class. So this again would be an indication that the child needs an eye exam and possibly glasses. So observe, teach, prevent, and refer and rehabilitate are basically the nursing interventions that we use. But you just want to recognize that these are symptoms of a child who's struggling to see clearly, and they're getting these headaches from not being able to see and from squinting and trying really hard to focus. And then they're having a hard time seeing their schoolwork or their homework, or can't see the board, and so they probably need glasses. So let's talk about some of our infectious and inflammatory stuff. So conjunctivitis is an inflammation of the conjunctiva, which is the mucous membrane that lines the eyelid. And it can be caused by a variety of pathogens. Bacterial is concerning because it can cause blindness. Most conjunctivitis is viral, but we don't really want to hang out for 7 to 10 days to see if the virus clears on its own, all the while you're developing blindness from your bacterial conjunctivitis. So we tend to treat all of these as if they are bacterial just in case. And, so this is one of those conditions where we way overtreat with antibiotics for viruses, just because the side effect of the bacterium is significant. It also can occur from a blocked lacrimal or tear duct, and when this happens, oftentimes the sclera itself doesn't get red, but the eye gets very swollen and inflamed, and there's discharge. So this is what is commonly referred to as pink eye, and warm compresses help to kind of loosen the crusts on the eyelashes and the surrounding structures. Topical antibiotic eye drops or eye ointments work. And if this is a secondary conjunctivitis, meaning that it's caused by a sinus infection that backed up the lacrimal duct into the eye, then oral antibiotics for the sinus infection will also treat the conjunctivitis. So symptoms include itching, tearing, edema of the eyelids and preorbital tissues, and then a very distracted or irritable child. If this occurs in a young child, we recommend that the parents do warm compresses to the eye with each feeding, just to make sure that they're doing the compresses often enough. And bacterial conjunctivitis is highly, highly contagious, as is viral. So lots of good hand hygiene, cleaning of surfaces. Gonorrhea and chlamydia are causes of bacterial conjunctivitis that can cause blindness. So if we see this true conjunctivitis with reddened sclera in the newborn, it's kind of an emergency because it can cause the neonatal blindness. So we want to make sure that it does get treated with antibiotics right away. Hyphema is a presence of blood in the anterior chamber of the eye. So you can see here when you look at the iris that there's like this little pocket of blood at the bottom. And it's caused by trauma to the eyeball itself. So sometimes it's small, and sometimes it's large and incredibly dramatic. So you want to position the child with the head of the bed at 30 to 45 degrees just to decrease the pressure to the eye and the head. And then medications may also be prescribed if there is like a corneal abrasion or some sort of superficial injury to the eye, but this usually resolves on its own, and then just monitoring for any secondary injuries or complications. So the blood changes with positioning of the child. So if the child's on its side, the blood is dependent and would also be on the side rather than at the bottom. So some vocabulary. Myopia is nearsightedness, when children can only see up close, and hyperopia is farsightedness, and both of these would end up with eye strain and be referred for eye exams and glasses. And then cataract. So cataract is when there's an opacity of the lens of the eye. This is the most common cause of blindness in adults, but cataracts also occur in children. And the cure for this is a lens replacement. And lastly, let's talk about retinoblastoma. So retinoblastoma is a malignant tumor of the retina, and manifestations include this yellowish white reflex seen in the pupil because the tumor is behind the lens in the retina. So this is called a cat's eye reflex or leukochuria, and you can see this in the right eye of the child in this picture. It may be accompanied by loss of vision, strabismus, which is the cross eye, hyphema, so blood in that anterior chamber, and advanced tumors will also cause pain. Treatment includes laser photocoagulation, so they use laser therapy to kind of break up the tumor and stop the blood flow, chemotherapy, external beam irradiation, which is radiation treatment, and then usually removal of the affected eye if no possibility exists to save the vision, and then they would have like a glass eye. So for the child who's having eye surgery, priorities include education of the parents, emotional support, dressings and eye patches, and then remove the patches as soon as possible to limit anxiety. And while a child, or an adult for that matter, has an eye patch on, remember to treat them as if they were visually impaired. So when you knock on the door, you always introduce yourself. Hi, it's Inga. I'm the nurse taking care of you today. I'm just coming in to check your sheets or whatever. Like, I'm at the foot of your bed. I'm going to touch your left leg. Like, always make sure that you're talking through so that you don't startle them or scare them. Elbow restraints are used, especially in younger children, to protect dressings, sutures, and the eyes. And it's important to avoid injuries to the eyes. So this would include when they're sleeping, avoid any injuries from the pillows. So maybe propping them so they can't roll and push their face into the eyes. So that's what I have for you today. Thanks for watching.